Hello, I'm Ileana Pina from Wayne State University and the Detroit Medical Center, and I am here in New Orleans at the American College of Cardiology, where there's a lot of buzz. The exhibition center is full of energy, and a lot of good work is being presented. And I'm happy to have with me today Dr. Rollman from UPMC. You are the Director of Behavioral Health.
A director of the Center for Behavioral Health and Smart Technology, and also Professor of Medicine
Wonderful.
at the University of Pittsburgh.
So you had a presentation yesterday.
I did.
Tell us about your study and tell us about the funding that made this possible.
Sure. So we conducted the first clinical trial ever to look at the impact of treating both systolic heart failure and depression together versus doctors' usual care and also care management for heart failure alone.
Is that what you call blended care?
Yes, blended care.
Can you tell the audience a little bit more about blended care?
Sure, exactly. So it's based on something called the chronic care model that they may be familiar with. The chronic care model was developed.
The Wagner.
Exactly, the
model.
Ed Wagner. It's been shown to be effective for treating heart failure, for treating diabetes, hypertension, COPD, and other chronic diseases, including depression and anxiety, but had never before been treated for a heart failure population. Our team at the University of Pittsburgh published a paper in JAMA a couple of years ago looking at the impact of treating post-CABG depression, and we found that these patients recovered faster, they had less pain, and significantly it saved a median of about $2,000 a year in after bypass surgery if their depression was recognized and treated. And our treatment method was all done over the phone with medical nurses contacting patients, recommending lifestyle changes, socialization, getting adequate sleep, quitting smoking, physical activity, and medications if they were interested. What we found is that those patients, as I mentioned, significantly recovered, but I always wondered we had a usual care control group, and I always wondered if they improved simply because they had nurses calling them.
Somebody else talking to them.
Exactly,
yeah.
exactly. And just a caring individual. And there may be some non-specific benefits. So the Hopeful Heart trial, which we recently finished and opened the blind, was a $7.5 million NIH-funded trial.
Is it NHLBI or is it the Institute on Aging?
NHLBI, National Heart, Lung, and Blood Institute. So we had zero funding from the device or drug industry. So this is all the U.S. taxpayer dollar funded. And we had a team of study nurses who screened heart failure patients for depression at 8 Pittsburgh area hospitals.
Why did you pick HFrEF? Heart failure?
Yeah, it's a great question. I'm an internist by training, and I see also when I attend on the medical wards a lot of what I call chart lore, where people are labeled as having heart failure, but it's unclear if they have HFrEF or preserved function, or if they have heart failure at all, maybe COPD. So we required people have an ejection fraction of at least 45% documented.
So you were really specific. You were
Exactly.
actually looking for them.
Exactly. At the end of the day, we didn't want people to say, we had a mix of heart failure patients. Maybe some people really had COPD and were accidentally put in the mix or had some other kind of condition.
It's a good idea to have been very clean about your inclusion.
Exactly. So all of the patients, we enrolled a total of 756, and all of them had ejection fraction of 45% or lower. And in my presentation yesterday, we presented the mean ejection fraction was 28%.
So this is the real McCoy.
Yes,
Yeah.
and people also had to have New York Heart Association classification 2, 3, or 4 heart failure. So they had to be somewhat symptomatic.
Yeah.
Exactly.
But how did you determine if they were depressed or not? What instruments did you use?
Well, interestingly, so we're sitting in front of American College of Cardiology logo, and in 2008, the American College of Cardiology and the American Heart Association published a recommendation, a joint guideline, advocating routine screening of cardiac patients for depression using the PHQ-2 followed by the PHQ-9. And so this is like 11 years ago, and I'm
so
not...
why the two instruments?
Sure, well the PHQ-2 is a screen.
Right.
So, and the questions are, do you feel down, depressed, or hopeless on most days in the last 2 weeks, or tired or little energy? So we screened people in the hospital, but we didn't want to call people depressed in the hospital because the symptoms of being in the hospital and having a heart failure exacerbation like little energy, trouble
Yeah,
sleeping.
they go together with
Absolutely.
the symptomatic. Yeah.
So we call people up 2 weeks after they were discharged home and rescreened them with the PHQ-9.
Ah, so you use the 2 first and then the 9 to.
That's
got
right.
it. Got it. Okay.
So in the ACC, AHA guideline that was published in JAC and Circulation jointly, they didn't recommend how far apart to do the second part screening. So for us, there were practical matters. We needed to consent people, and these were the only time our team met the patients face to face. So we needed to consent in person, according to our IRB. So we screened with the PHQ-2 in the hospital, and then called people 2 weeks later with the PHQ-9. And we found that 46% of patients screened positive for depression in the hospital, but when we called those people 2 weeks later, 36% scored a 10 or above on the PHQ-9, indicating a clinically significant elevated level of mood
So that's the
symptoms.
number that you use as sort of the dividing line.
Yes.
How does that compare to the BDI?
Sure.
Because I look at the BDI and I think greater than 14 is very significant depression.
Well, so I'm a very practical guy, and the BDI is about 17 items, and there are different versions. Well, the PHQ-9 is 9. And so the PHQ-9 is the more current way of screening for depression. It's been popularized by the Robert Wood Johnson Foundation, the MacArthur Foundation. They both had initiatives on screening and treating depression in the, I don't know what decade we call that, the OOs. But so the PHQ-9 is like the most popular right now used in clinical practice. And it's a shorter response burden. It can be administered over the telephone. And it's easy to remember the cutoffs. So you have 10, 15, and 20 or above. The max score is a 27.
That's severe.
Yeah.
Okay.
So, but the clinically significant, no mood symptoms are 5 or less.
Okay.
Very mild or under a 10, mild to moderate or 10. So it has 5-point cutoffs. 10 to 15 and 15 to 20 would be a moderate.
Okay. So then those are the people you randomized?
Yes. In addition, let me add too, that we knew at the start that some of these patients would die, some would be readmitted or develop other issues. So we also enrolled a non-depressed comparison cohort of heart failure patients.
Which became your control, basically.
Well, actually, we had 2 controls.
Okay.
So the non-depressed comparison patients screened negative for depression in the hospital, and then 2 weeks later, they scored under a 5.
So they were really not depressed.
Truly not depressed, because again, and many of these people died or were readmitted over the course of time.
And your follow-up time after the randomization was how long?
Our primary outcome point is at 12 months.
Okay.
And our main outcome measure is health-related quality of life.
Okay.
And mood symptoms, as well as readmission, cardiac function is measured with a Kansas City cardiomyopathy
KCCQ.
questionnaire. Yes.
We've
The
talked about the
SF-12.
KCCQ on my blog often.
So those were all secondary measures, but health-related quality of life was number 1, and then also healthcare costs are key, and mortality.
And what were your results?
So as I mentioned before, number 1, depression was really common. It was almost half the patients in the inpatient setting, and a third of those patients had persistent elevations in mood symptoms 2 weeks after discharge home. Number 1. Number 2, at baseline, the patients who were depressed compared to the non-depressed controls were essentially similar on ejection fraction. We're both 28%.
So it wasn't a clinical difference?
No, that's exactly right. So the rates of diabetes, hypertension, post-MI, bypass, use of beta
Same.
blockers, exactly.
Same.
But when they self-reported their health, they were more likely to be in class 3 or 4, New York Association class 3 or 4 heart failure. They rated their function lower on the Kansas City
I saw the
cardiomyopathy.
KCCQ scores were pretty low in that group.
Yes, and really, essentially, the only major difference was the mood symptoms. Now, over the course of follow-up, what we found is that the blended model of nurse-delivered over the telephone collaborative care, we were able to support our primary hypothesis, being that patients who were randomized to the blended model had significantly improved health-related quality of life as measured by the SF-12 MCS, compared to patients who were randomized to their doctor's usual care. And when we also compared, we wanted to have the attention care control I mentioned at the beginning with our earlier bypass work in JAMA. I was unclear about whether the improvement we observed was related to the non-specific calls or not. But I can tell you now conclusively, the patients who were randomized to the blended model also had significantly reduced levels of mood symptoms compared to the patients who were randomized to the collaborative care for heart failure alone, as well as to the usual care. So in those cases, our primary hypothesis measures were supported. On the other hand, to date, we have not seen a reduction in hospital readmission. So you saw my slides, and the overall incidence of readmission to the hospital was 90% roughly among the depressed and 75% among the non-depressed. But what we didn't
And that
get,
wasn't statistically significant?
well, it was kind of close.
Maybe,
But there was a problem with the
Yeah.
Kaplan-Meier analyses, is that some of the patients were hospitalized 10 or 20 times, and the Kaplan-Meier
only captures one.
bingo.
Yeah.
So,
So you should do the repeated events type of analysis.
exactly. And what's
Because-
the median number? Exactly as you say, because maybe there might be differences there. Now, you only die once. So the other thing is with the mortality data, we had a roughly...
You're not available for another hospitalization.
Exactly. So we had about a 14.5% versus a 10.5% incidence of mortality. This is all-cause
It's
mortality.
still pretty encouraging, though, those two, 75 and 90%.
Yeah.
So what's next for you?
Well, we need to do a couple things. We need to delve down. I mean, we literally only opened the blind a couple weeks ago.
We're going to look at gender differences?
We are, and we looked at that too, and that's important in studies of heart disease and depression. Women are twice as likely, as you know, to experience depression or anxiety disorders as men. And so we powered our trial based on within gender
You
differences.
have half and half.
Yes.
So you've got enough women in there that you should be able to analyze it. Well, we're going to be looking forward to your next study.
Yeah.
And I may ask you back again.
Well, the other thing...
What do you want to tell doctors?
Well, I guess a couple of things. The bumper sticker is that depression kills. If I had
There
to
you go.
if I had to boil it down to two words, depression kills. So it's really important to consider the ACC and AHA guidelines about screening your patients for depression, particularly if they're not getting well. If you have them on maximal therapy
They're
for
still
heart failure,
symptomatic.
you know, they're on the right ACE inhibitors, they're on maybe they have the AICD, and they're still reporting really poor quality of life. It's very, very important to consider that this person may have comorbid depression or anxiety. Now, there are a number of heart failure care management programs around the country. You know, the VA and UPMC and Highmark and Intermountain. They have these kind of Kaiser, they have these care management programs, collaborative care programs for heart failure, but to the best of my knowledge, they don't routinely screen for depression.
No.
So I think for our cardiologists in the room and primary care doctors, it could be routinely assigned to the nurse care managers in these heart failure
And it's
programs.
very easy to give the
Absolutely.
questionnaire in the office. You know, we were doing the BDI years ago in the clinic, and we've talked about this on this blog before. In our world, about 35 to 40% of heart failure patients are depressed.
Yeah.
And of course, now we're writing an American Heart paper about medication adherence and what an impact depression can have on medication adherence.
Okay.
So it's another idea for you is to actually see what happened to medication adherence
We will
in
be
your,
looking, yeah, we'll
in your
definitely be looking at
collaborative
that.
group.
Now, some of your viewers may also be paid on pay for performance. In which case, you know, like looking at the rates of ACE inhibitors and beta blockers.
Exactly.
And so, again, you know, if your patients aren't on the right medications, could it be because if they have comorbid mental illness issues?
Or they're not taking them.
Exactly.
And that's the whole issue for us has been adherence.
Yeah.
Well, I want to thank you for coming today, and I want to wish you a lot of luck because this is the kind of work that you don't get a pharmaceutical company, you don't get a device company to pay for it. So kudos to the NHLBI
Thank you
for
very
having
much.
taken this on. And I wish you luck on the next, I hope you finish off this data set. You've got a lot of work inside this data
Totally.
set to do.
Now, if your readers, if your viewers come to our website at www.hopefulheart.pitt.edu, they could download some of our study instruments like the
Fantastic.
PHQ, all free and also linked to the
I'm going to be
papers.
doing that for my clinic. I'm going to be downloading that. So thanks again.
Thank you very much.
I want to say thank you to our viewers. I hope you find this very interesting. I certainly do, and it's stuff that you can put right into practice in your own clinic, and your patients may appreciate it much more. This is Ileana Pena signing off from New Orleans at the ACC. Have a great day.